My name is Dr. Jessica Parlor. I am a clinical psychologist, really excited to bring this talk to the OCD community today. And I will pass it on to the other panelists who will now introduce themselves. Sarosh?
Hi, everyone. My name is... Sorry, just a brief intro for now. Hi, everyone. My name is Vinay Krishnan. I am over here in Brooklyn right now, isolated. I'm the national field organizer for the Center for Popular Democracy. And we do a lot of work on healthcare campaigns, specifically fighting for Medicare-for-All, fighting to lower prescription drug prices, fighting to combat the overdose epidemic. And as I'm sure you can imagine, that mental health kind of interweaves throughout all of those issues, and something we're kind of managing and dealing with every day. And on the side, I'm a writer. Jessica, do you want me to keep going for now, or do you want to do brief intros of everybody first?
The introduction of the others first, and then we'll have you start off with the sharing.
Yeah. Well, my name is Tawana Watson, and by day, I'm an accountant, I guess you could say. I am also an advocate for mental health and women's health and minority health care, and just I'm a very busy person. I have created my own nonprofit here in Cleveland, Ohio, called My Sister's Keeper of Northeast Ohio. And through that organization, I got my certification as a lobbyist here in the state of Ohio to try to get laws changed to help with different types of issues as it comes to mental health, women, or whatever have you. I also am a writer. I'm writing my first trilogy, actually. I'm almost done with the first book of my trilogy. And what else? I do a lot of stuff. And I'm so happy to be a part of this tonight.
Awesome. I'm Sarosh Motivala. I'm a clinical psychologist based in Los Angeles. I have my own practice specializing in OCD, and I also work at UCLA's OCD intensive treatment program. And I've been helping folks with OCD since about 2011.
Awesome. So these are our panelists. Very excited to have everyone join us this evening. We're going to start the discussion with Vinay and Tawana, who will share about their work and also their experience in the OCD community. Vinay?
Sure, yeah. So again, just thank you for having me, especially during Minority Mental Health Month. I think this is a really kind of unique event, unique opportunity to talk about issues that I would argue are really more important now than maybe they've ever been. And I think later on in the discussion, I can elaborate on why. But just to give you some backstory, grew up in New York. I would say my OCD symptoms started in 8th grade, so I guess I was 13. And I did not see a doctor or get diagnosed until I was 24, so that's 11 years without treatment. And I don't know for sure, but I'm going to go ahead and guess that that's a very similar story to lots of people who are listening to this, maybe even some of my panelists. All people go without treatment for mental health for years typically, and minority communities it's usually longer. I think tonight we'll kind of delve into some of the reasons why. My kind of OCD, if that's helpful for anyone out there, it's harm OCD. I have lots of sessions about harm coming to those around me, my loved ones, either they're just by accident, by attack by a third party. Sometimes I'm the one doing the harm. So usually kind of very violent imagery, that sort of thing. So if that's something anyone wants to hear more about, feel free to ask questions or we can talk offline. For my work, as I mentioned before, it's very healthcare based. Work with lots of disabilities, people managing different illnesses, especially right now during COVID, people who are really struggling to make ends meet, people struggling to find affordable care. I don't really like using that word affordable. I think it should be free care, but right now we're stuck with trying to find affordable care. And so, yeah, that's the work I've been doing in terms of my mental health advocacy, the way I found myself to this council in particular. I'll tell you a quick story, which I think kind of encapsulates a lot of why I do this work. And some disagree, but I think people growing up with OCD, it's very much the shame illness. I think everyone who has OCD carries a great deal of shame with them, because from a very early age, you're kind of wrestling with questions of, can I be trusted? What am I capable of? Why do I have these thoughts in my head? There's just lots of shame associated with it. And the reason I love the IOCDF, I think the single most powerful moment I've had with the IOCDF was my first conference in San Francisco. And we were in the keynote room for the keynote address. And it didn't even matter who was speaking. It was just like standing in that room with 2,000 people, maybe like 1,800 people, who all kind of understood what it was like to have this illness. One of the most powerful things I've ever experienced. Because I just kept flashing back to when I was a kid, 13-year-old, just like convinced, like 100% convinced that I was alone in the world, that I was the only one obsessing about these things, especially these violent things. And, it was just some like freak, some monster. And then, you go 11 years later, the doctor tells you, you're not a monster, you just have an illness. But you can't like unflip that switch, right? You're still like kind of embedded in your brain. But standing in that room with 1,800 people, I was like, yeah, I'm one of these people. This is my community. This is where I belong. And it's incredibly powerful, so I'll always be grateful to IOCDF for that. But I will say one caveat, and that's kind of the reason we're here. How much more powerful would that moment have been if there were other people in that room who actually looked like me? And there definitely were not. I think we're all familiar with how white the spaces are. So yeah, I think just like combating that shame, that stigma is a big role for mental health organizations. And if a town hall event like this or other events we might hold, I know that there's going to be 4 of these. Anything that ISVF can do to kind of model these type of discussions, decrease that stigma. That's kind of, I think that's why I joined the council. So I think we're gonna dive into a couple different issues, but I think that's how I wanted to start off.
Awesome. So much. Tawana?
Okay, well, like most people, my symptoms started when I was young. And I remember a time where I tell everybody now that I felt my mind split in 2. I was on a school bus, I think 8th grade or something, and my mind split. But because of my culture being African American, I really didn't discuss it with anybody. So 17 years ago, I have 4 children. When they were little, I knew something was wrong. I ended up going to a hospital here in Cleveland and met a psychiatrist and was misdiagnosed. She told me that I had schizophrenia. She told me I was bipolar. She told I was manic depressive. And she prescribed me a whole slew of medications, which made me gain from 120 to 300 pounds in 3 months. So I don't recommend this to anyone. I took myself off all the medications cold turkey, went through the withdrawal or whatever. And then my father, being a preacher, told me, all you need is Jesus. So I started going to church, and then I got scrupulosity. I don't know if I'm saying it right, but I got that, where I got so obsessed with, I got to pray. If I don't pray, my day is not going to get done. If I don't go to church, Jesus is going to be mad at me and my day is going to be messed up, or my life is going to be ruined. So that got really, really bad for me and for my children. And also my kids, now that they're grown, before I went to get treatment, they used to be at home and I knew what was going on. Logically, I knew they were home at their house, or I knew they were at work, and I would call them. If they did not answer their phone, I would then call them and call them and call them and call them and call them until they answered. And if they didn't answer, I would call the police. I would call the fire department. I called jails. I called hospitals. And it got to the point where it was like really bad. And that happened with a lot of different family members too. So in 2017, I had a nervous breakdown. I had got to the point where I was afraid to leave the house because I thought somebody was going to kill me. And I laid on the floor and I wouldn't get off the floor. And I ended up going to the Cleveland Clinic, and I met my current psychiatrist and my therapist. And from talking to them for 5 minutes, they told me what was wrong. They told me it's OCD. She put me, and I'm not an advertisement for medication, but I was put on Zoloft, and Zoloft to me was a godsend. And I have been noticing within the African American community, because I've talked to a lot of people, they don't talk about it because of, oh, well, you just suck it up. Like my father, he does not discuss anything therapeutic or anything. He doesn't believe in it. So we were taught that growing up. Psychiatry is a myth. You don't need that. You need to go to church. You need to pray more. Something you did in your life made Jesus mad. Therefore, that's why you have the symptoms you have. But I'm like the black sheep, and I started going and talking to people and finding out that it's more people like me that has this disorder that don't know what it is. And then they have different, and I don't want to get ahead of anybody on the panel, but there's different reasons they can't seek help or they won't seek help. Part of that is the financial portion of that. I'm very, very lucky to have great insurance because I see my therapist every 2 weeks. And I see my psychiatrist, every 3 weeks. I have that. Other people don't have that. And that's the bulk part of why I started my organization, to try to get our government here to make a stipend in the budget for people who can't afford it so they could get the treatment that they need. And maybe then that'll decrease the homeless population and everything else. And that's pretty much my whole thing. And I have a big mouth. If you guys listen to my podcast, it's like an open book. I tell you about my whole entire family, about my symptoms, about being a Black woman with this disorder, having parents and a family that's totally against it. Because my family has it. I mean, my mother she hoards. My daughter, she stacks stuff symmetrically. My sister, she cleans stuff, but they don't think it's an issue. And we need to educate the communities. Period. That's how I feel about it. And I'm so glad to have this platform to express that.
Nice. Sarosh.
A couple of the things that I've observed are that it's kind of, first is what Tawana brought up, which is, and she brought up a bunch of really important points, actually. The first one that stuck in my mind, though, was this issue of, people's own personal, familial and cultural beliefs about mental health and getting treatment. What can we do? What can I do as a psychologist in this community? What can I do to address that? And I thought it was actually an easy answer. It's actually not that easy. It's really complicated. And I'm still trying to figure out how to do that, how to make that happen, how to do outreach on a personal level, how to do outreach on a bigger level. Obviously, serving on the Diversity Council is one strategy there. Being a part of something great like this, TBIS-TBF, is one strategy. But it's hard. I'm still trying to make my way and figure things out because I, too, in the past have had family members and friends in my community. I was born in India, raised here in the U.S., but I remember hearing one comment at one big get-together we had, which was that anxiety and OCD, that's an American problem. Mm-hmm. Indians don't get OCD, which I think is kind of funny because we do, So that's one big piece is outreach. The second big piece, which again Tawana mentioned pretty prominently, which is accessibility. How do we make this affordable, right, and accessible? And that's a brutal one. That's tough too. I work in Los Angeles, and I get calls a lot of people saying, I live here, where can I go? And I tell them, I don't know, because where can I go that takes my insurance? And a lot of psychologists, myself included, we don't take insurance here in Los Angeles. And so, it's a dilemma. I mean, you can blame us as therapists, and that would be fine. But, we're trying to make ends meet too. Right. And then, if you spent a few years fee for service trying to learn how to navigate through the health insurance system is complicated. It's really complicated, and they don't reimburse quickly. So we have to figure out models of making ends meet that factor that in, and it's not that easy. So, so accessibility and affordability are key issues. And then there's a third big issue, which is trust.
Yeah.
And there are some communities that are just not Black community. For example, where there is an extended period of time where the healthcare system has not done right by that community consistently. So it's actually very rational and reasonable to be very suspicious and mistrustful of the healthcare system. And in working with practitioners in a large enterprise like UCLA, a lot of practitioners are surprised and don't understand. I think less so these days. I think people are starting to get it, surprisingly, but are surprised that we don't get it. We put out our shingle, we've opened this clinic, nobody's coming. What's going on? And I think part of it is, in order to accommodate or address this issue of repeated violations, like profound violations, you're going to have to do things when you open a clinic to address that. You're going to have to take the time to build relationships with people in order to get people to start trusting you, and it's going to take a while.
Right. Excellent. And just because we're into the disparities that Vinay and Tawana both mentioned, and then Sarosh giving us that clinician perspective on it, I'm wondering if Vinay and Tawana can both talk about some of the unique, specific efforts that both of you have engaged in. Tawana kind of mentioned briefly the effort with the government in Cleveland, and I know Sarosh has some really specific things that he's involved in as well that address the disparity, specifically like outreach and affordable, appropriate care, if you could share.
Well, I'm trying to get, because a lot of people I talk to, African-American people, say that they don't go to therapists because there's not a Black therapist. And a Black person, a Caucasian or different type of therapist does not know what the Black people go through. And so I'm trying to push Cleveland Clinic here. And I don't know if you guys have heard of Cleveland Clinic. It's pretty big. And I did a survey, and there's not one Black therapist in the whole entire Cleveland Clinic. There's not one Black psychiatrist in the whole entire Cleveland Clinic. And I know that's a preference because a lot of people like their preference. I like female doctors to take care of me. And if you like to have a therapist or a doctor that's the same culture as you because you feel that they understand you better, then that should be. And I've been talking to a lot of different Cleveland State, Ohio State to see if they could give grants to minorities to try to, get them to go to school to become a therapist or something. And unfortunately, covert put a stop that cold turkey. But I'm hoping after this the pandemic passed, I could pick that back up. Because that's a main issue. Education in the Black communities is a main issue. It's not just religion. It's not just going to church. I'm a testimony to that. I was going to church. I was doing the right thing, and I still had a nervous breakdown. And we have to educate the younger children about it too. It's nothing to be ashamed of. Like Cleveland Public Schools here refuse to have anybody come in there to talk to them about suicide or any type of mental health stuff. And I think that's very, very bad. Because you get it when you're young. So I'm doing a lot to try to change it.
On that access to education, right? Access to healthcare, those things can tend to go hand in hand and impact communities. Vinay? Can't hear you. We can't hear you. We can't hear you.
I'm unmuted now. All right.
There we go.
Just a little Zoom joke. We're just having fun here. Don't worry about it. You missed all the important stuff. So now I'm gonna anyway. So SAMHSA did a report. The latest data is available from 2018. But according to SAMHSA, In that year, 2018, 18.6% of non-Hispanic whites received mental health services. And we're just gonna go lower and lower here. That's compared to 14% of American Indian/Alaska Natives, 11% of Native Hawaiian Pacific Islanders, 9% of Hispanics, Latinos, 8.8% of non-Hispanic African Americans, 6.3% of Asian Americans.
Right.
And then I think my good friend Fran is going to share a link in the chat to this campaign by a partner organization of ours called Social Security Works. And they have a campaign called All Means All, which addresses the racial disparities in health. I can maybe drop in the chat. Fran didn't, maybe he did already. But it gives you a fact sheet for every state, all 50 states. So you can go there, we'll share the link, and you can look up your state. You can also look up your local congressional district, and it'll give you a racial breakdown of who is insured and uninsured in your state. So I just quickly looked up New York, because I'm from New York. And it says about 1 million New Yorkers are uninsured, and 60% of New York's uninsured population are minorities. And I know we have two panelists from Los Angeles, I believe, from California. Let's go California. California, 2.7 million are uninsured, and 80% of those are minorities. So those are wild numbers. Like, we're not talking about like a small kind of niche problem here. This is like systemic. This is like widespread. This is something that like has to change. So those are some stats, and then it's like a big picture view. I can bring it down like anecdotally, just to echo what Tawana said about having a therapist who doesn't understand who they're talking to. From like an Indian perspective in the South Asian community, mental health is not really something people talk about too much. It's very repressed. It's not something you're supposed to talk about. And I had a white family therapist. I was in an inpatient program, and I had a therapist who was very insistent that I just like talk to my family and just like be very open and tell them everything. And I was like, that's not how this works. It's like it took me like long enough just to tell them I was coming here. I can't tell them. And especially when you have these like hyper violent obsessions, I'm like, I can't talk to them about that stuff. And then she just like didn't understand. She didn't know why I was so hesitant. And she didn't understand to the point that there was a certain sense of judgment there. Like I was doing something wrong. Like I wasn't like committing myself to the treatment. I wasn't giving it like 110%. And I'm like, no, I'm in an inpatient program. Like I'm here to get better. This isn't cheap. But that's just not how things work in my family or my culture. So that's not something therapists always understand. In terms of like what we're doing about it, my organization is really working hard towards Medicare-for-All, which I guess seems a little more far-fetched right now than it did a couple months ago. But we're still working towards, based on the belief that if you are sick, you should be able to see a doctor. And that's a principle we agree with. And there are like other bills that also embody that spirit right now during COVID, certain bills that would cover care throughout the duration of the crisis. So I do a lot of like digital lobby visits with senators and representatives kind of talking about those bills. I guess I can tell you a story about one. I think the panelists have heard this story before. It seems relevant at this point, just in terms of the stigmas we have to overcome and the ignorance we have to overcome. I guess in this forum, maybe I won't mention who the senator was, but just, I don't know. I want to, but there's no point. Right. But I met with the senator's office talking about these issues, plugging these healthcare bills. And whenever I do this, I'll bring in constituents from the senator to tell like on the ground stories because, I'm this advocate in New York. I shouldn't be the one carrying this message. So we bring in constituents to do it. And this is, a constituent talking to the representative's healthcare staffer, tells a very emotional story involving suicide. And this is, the healthcare staffer for the senator replies saying, the thing about suicide is you can't really treat it. There's nothing you can do about it. He talked about it as if it was like this magical thing in some like sci-fi movie that like we just like conjure up and don't understand. And I'm just like sitting there like, no, like of course we can treat it. Like this is the healthcare staffer for a senator, a sitting senator. There's only 50 of them. And he had no idea what the hell he was talking about or the curse there. So if someone in that position is telling this man who was an African-American that, he's invalid, his suffering isn't valid, pain isn't valid, illness isn't real, Like, just imagine like how much more work we have to do, how much stigma we have to fight. That was really disheartening. And I guess we're still talking about access insurance and all those things. So feeding off that, I'll tell another like super personal story. And that is my personal health reached rock bottom in January and February of this year. And I became incredibly suicidal, and I went and I was hospitalized for 8 days in the hospital because I wasn't safe to be on my own. And while I was there, they ran this like new test that they're recently rolling out, and they found that I have a genetic anomaly. It's sort of like a rare thing. Like, I don't have the proper serotonin receptors, so SSRIs never worked on me. And no doctor had ever like figured this out. I've been on like 20, 25 different meds over 8 years, and none of them ever worked. Like maybe like a marginal improvement here and there, but I've pretty much just been, agonizing with this disorder since then. And the doctor's like, yeah, of course you've been. Like, none of those meds, apply to you. And then they're like, let's try this other med, which isn't really, prescribed anymore because, it has XYZ side effects, but it should work for you. And, 6-8 weeks later, once it started taking effect, now I'm like healthier than I've ever been. Like, no depression, no suicidal urges. The OCD is still there, but it's much more manageable. Mm-hmm. I'm telling you this story because that entire narrative, like from A to B, is completely impossible if you don't have insurance. There is no way I could have paid for any of those, any step along the way. That would have been completely impossible. But I'm privileged to work at an organization that provides very good insurance for its employers. And this was like right at the beginning of COVID. So let's say like I lost my job because of COVID, as so many people have right now. All those people, that story is impossible for them right now. We're living in a country where insurance is tied to employment, and that shouldn't be the case. And that's disproportionately affecting people who look like us. So I'll pass it on for now.
Thank you both. And I wonder if Sarosh, I know that you've had experience, I'm early career, you've had experience in training. You've also seen the treatment evolve and maybe make some progress and maybe take some steps back. Would you be willing to speak to a couple of those points around that?
Sure. When I was working at UCLA and I came aboard to their OCD treatment program, a big piece, this was 2011, and there was a huge paper. I forget when it was published, but it was it's cited a lot, and it's the number of years you get adequate treatment for OCD, psychotherapy treatment, so ERP, exposure and response prevention. And at the time, now there's a few papers out there on this. There's some studies that say it can take as long as 17 years to get adequate treatment. And I think that time span has shrunk a bit, but it's still just absurdly too long. So what we became really interested in doing was, how do we export training of therapists? And we tried a bunch of different strategies, and we kind of settled on one, which is training doctoral students and training psychiatry residents. We've set up training programs through our IOP for that, and it's pretty awesome. I love it. I love working with our students and residents. It's sort of a shame. I'm sort of embarrassed to say this because I don't want to get anyone in trouble, but our students and residents are more diverse than our patient population. So, and I kind of feel bad saying that because, we all want to do the right thing, but I think we have to sort of see what we're looking at. And this is a fundamental problem. And that's what brought me to sort of get involved with the Diversity Council at the IOCF. And, okay, this is a problem. How do we address it? And at the time, I thought it was all outreach. It's got to be all outreach. And now I've changed my mind quite a bit, and there's just a lot of barriers. And this is going to take a while, and it's going to take a lot of work. But one key piece that we started is let's export training to licensed therapists, so that we can. It's not a specialized community or as small of a community of therapists. And how do we export training in a way that makes access to this treatment much more accessible. So the IOCDF has these training programs already set up. And I think that's been incredibly successful. So I think step 2 is to start thinking about how can we advertise and export these training programs to licensed therapists who come from a diversity of cultural backgrounds, ethnic backgrounds. So I think that's going to be an important piece. So taking training to them, I think, is really key. The other crazy thing is, so I did this YouTube video on OCD. It was through a UCLA talk that I gave. And because of that video, I get emails pretty routinely from people all over the place. And because I have an Indian sounding name, I get a lot of emails from people in India and or a lot of people who are Indian American. And it's bad. Like, it's really bad. For a lot of the reasons Vinay talked about, very personally and eloquently, there's just such, and Tawana touched on this, there's such stigma. You almost need your family on board. And I've seen this in my work, like when a family's on board, the treatment is so different. Yes. When a family's not on board, it's tough for me as a psychologist. And it's obviously so tough for the client I'm working with. So I think step 2, this is the other thing I'm starting to think about, is if we're going to be culturally, and Jessica and I talked about this one time, the term cultural competency, which neither of us like very much, but what she introduced to me the term cultural humility, which I think is a fantastic sort of shift in how to view things. But if we're trying to adapt treatment to different groups of people, I think a next really cool wave is going to be, how do we integrate exposure and response prevention with the family? Right. How do we get them on board? I think that's going to be pretty killer. We just got a great family therapist into our IOP program. And I'm already learning a lot about how he thinks. Just so you guys know, out in the real world, how we get trained, psychology is kind of interesting, right? I mean, you're trained to zone in on one person, that person sitting across from us. And we almost try and exclude all this other stuff. And that's fine, but that's just one way of doing it. And there are other ways of doing it as well. And there's some really cool people doing some good family work. And it would be great to kind of explore how can we, as we export therapy and training, can we export that family work? What can we learn from therapists of different backgrounds? What can we learn from their experiences, their insights, and integrate that information into the model, into the exposure and response prevention model that we use? Because I've worked with clients who are coming from cultures that are pretty different than mine, and almost therapy naive, like they don't, and it's hard. It's hard. I used to at UCLA. I used to work in this treatment program where we'd work with student athletes, and I was really bad at it for a while. I thought I was really good at what I did, and then I worked with these kids, and I realized I have no way to connect with them. I don't speak the same language almost, because I'm used to, with my clients who have OCD, they've been in the system, the therapy system for so long. They understand all the terms. They understand therapy, the whole model. My clients through this athlete program, first of all, no offense, they're athletes. So their verbalness in therapy, they don't even want to talk too much in therapy. So I had to learn a whole new way to communicate. So it took me a while. And eventually I kind of got it and got better at it. But it takes time. So that's just one example of how, if you're trying to develop cultural competency, how do we actually kind of shift your orientation to being more to expressing and communicating cultural humility
Thank
and saying, I don't know this stuff. Can you tell me?
Yes.
But then how do you do it in a way that doesn't make you sound like you're a moron?
And to not,
know.
right, to not burden the person from the community in educating you while they're seeking treatment, right?
That's right.
It's an art and a science.
That's right.
Kind of a blend. Sarosh, could you actually speak a little bit to, as a clinician in both your private and working with a larger organization, how you observe the health disparities on who's seeking care, and if there are creative ways, and I happen to know that this is your passion, that you try to put together resources for people who are unable to access, care. But when you see somebody come in, and I think it was in the comments that a lot of people are turned away when they present with Medicaid and Medi-Cal. How, as a clinician, when you observe that, what are some of the options, and how that kind of drove you to start to gather some resources to address it?
Well, it's a large system that we're dealing with, and maybe some of the good work that Vinay and his organization are doing kind of plug into this, but I think all of us are little Davids dealing with a giant Goliath, and so I'm still pretty naive about a lot of these systems. And so I'm trying to use these opportunities to learn more about these systems, to kind of learn where access points are more reachable. So the first thing, to me, up front and center is cost. That is to me, that's the most important piece, is how do we make this affordable? And that might be the toughest one actually to work on, unfortunately. And every state is different. So I'm kind of narrowing my efforts to California and LA, the part that I can provide is to use my knowledge base to train clinicians that already take insurance. So clinicians through the DMH, the Department of Mental Health, who do accept Medicaid, or California's California version of Medicaid, to help start building inroads to maybe create a bit of a training model or training program for them. Another thing would be to kind of try and work with the IOCDF to create scholarships for training for BTTI, so they can get so licensed therapists who don't have a background in OCD can get trained, and it's not a huge amount of money out of pocket for them. So those are kind of the first steps, and I wish I had ready to, give resource information to people listening in, but
it speaks to how challenging it can be. You want to make sure it's a quality, appropriate therapist and treatment provider. And I am on the Diversity Council as well, working with the subcommittee to really outreach to minority clinicians who are already serving the population, want to continue to do that, and are interested in being more skill-based. So IOCDF is definitely interested in that, and hopefully we can ramp up some of those efforts, being that right now, not just July, but the social climate is critical. And Vinay already mentioned that so many minority communities do not have healthcare access to it, and this continued stress and chronic trauma in our environment is definitely going to have to be addressed. Vinay, there's a question about your genetic testing.
Yeah, I don't remember the name of the test, but I could certainly find out and email people. I can share that information.
I wanted to mention that just quickly, that somebody was curious. All right. So I also wanted to discuss a little bit more. We got into the cultural competency. Cultural humility is my preferred framework for welcoming someone into a space that is open to understanding their culture as a part of their treatment. And when we talked about therapists, I think Vinay and Tawana mentioning unique aspects of minority communities, truly family and social support is a huge, huge role. And just talking a little bit more, what would have been nice for the therapist to be curious about or to have been willing to talk about, and also who in our communities tend to have a voice, and how can clinicians and maybe even patients, our clients, be able to advocate better. To the clinicians, I need someone to hear me out, understand, and then how the clinicians can advocate to families. So Vinay, Tawana, either way.
Well, for me, on my personal experience, my therapist he's a Caucasian guy who actually took some training to learn about cultural stuff.
Yes.
But I trust him I really trust him. He knows that I have major trust issues. So he does not make promises he does not keep. He does not say things he's not going to follow through with. And that's for our culture, the African American culture, trust is a major thing. And when I call him, he calls back. You're not his nurse, he calls back. And I think that's a good thing. But see, like I said, it's a preference for everybody. I mean, I like him. He specializes in OCD, the spectrum. And he knows about the culture. He actually took the training. And another thing I want to mention is to overlook the cost. I know the cost is expensive. Trust me, I know. That's why here in Cleveland, I am working my butt off to get therapists and psychiatrists to at least do some pro bono with these people to help them get the care that they need. Because right now, I was talking to you, Jessica, I think yesterday, and I told you how they use the ER as a revolving door. Yes. They go in there, they get treated, and then they get put out a week later and do the whole cycle again. And we need to stop that. So I think if we could, everybody get together and put a network of therapists and psychiatrists together who are willing to say, okay, I could do this pro bono. And I'll go here and I'll educate them and I'll treat them and I'll give them what they need, the therapy they need or the psychiatric advice they need to pay the cost. Because I know the cost is outrageous.
People down that always, and I think Vinay might be able to speak and Sarosh as well, that in minority communities is uniquely concerning that they're not insured and yet use the ER as a primary medical health intervention. Because they're then not insured, the linkage from the ER, right, for aftercare plans are very limited, right? And then don't allow for that high level of care that somebody who often comes into the ER, they truly deserve a high level of treatment to wrap around them. So it kind of feeds back in to the healthcare disparities, right? And then the access. But the one I have to highlight, and Sarosh, this is the thing. So her clinician has training. Yes, he sought training, which is just great awareness. But he's a solid clinician who knew how to build trust and rapport with his patient regardless.
Well, he kicks my butt, trust me. he really...
No, but that says a lot that you trust him to do that, right? And so I want to even encourage clinicians and patients that if you are sitting in front of a quality therapist, you're going to get quality care, and hopefully they're aware of some of their blind spots and the things where they need to access further education and training to best respond to your needs. So thank you for sharing that in particular, the trust part. That is really important to any patient, but uniquely with minority communities entering into healthcare to treatment.
Right, because I tell him all the time, I'm like, Ken, you're going to tell me step by step what we're going to do. And he'll look at me and he was like, okay, because I know you got that control freak thing going on. So, it's like...
like a good understanding and a level of trust.
So important. So important.
Critical.
Yeah.
wanted you to say a little more about the people that you're training. I think it's really interesting that you're training diverse clinicians, which on one hand is beautiful. Like, I mean, we love hearing that. That means more people in the field representing and reflecting our population. How has that been to not only train diverse clinicians, but train them on a population that is not as diverse? How do you talk about trust and all of these other issues?
Oh, I don't know. It's trust is a foundational. Building trust is foundational in any form of therapy. So, what do you need to build trust? Is you want to communicate competency, right? You know what you're doing, so there's strategies to do that. And then you also want to communicate. Well, I mean, I'm a CBT guy, so for us, it's really important for us to communicate collaboration. So you and I are doing this together. I have my expertise, you have your expertise. Your life experience, how you've handled your mental health, how you live your life. You have expertise in those areas. You have knowledge about those expertise. We're going to use that, and we're going to collaborate together. And by me communicating just routinely, repetitively, in how we work together, that this is a collaborative thing. So, like, if we're building a hierarchy together, if we're doing an exposure today, how do we come up with what the exposure is? Will I just tell you what it is? Well, that doesn't sound collaborative then, does it?
Right.
Do I give you options? How much do I lead the session versus I lead the session, but I'm routinely checking for your input. So collaborate. So communicating expertise, communicating a collaborative approach are two ways to build trust. And the third big piece is I hear you. I hear where you're at. I'm not going to invalidate you. I think that third piece is really key. And if we're dealing with someone from a really different ethnic or cultural group than where we are, or what we're used to working with, then we've got to communicate a fourth piece, which is, how do I put this? It's almost a blend of. Okay, I'll tell you a story. Sorry, it's not too long. But I had a friend of mine who moved from India when we were both kids, and I took him to a Dodger game. And he was asked, like, there's no baseball in India. So he was asking me, what's that? What is that called? And so he finally asked me a question, and I looked at him and I was like, I don't know. I don't know what that means. I don't know what that's about. Years later, he tells me, I really liked, when we really became friends, and I was like, what? When we went to that baseball game, and I was asking you all these questions, and then you said, I don't know. Because it communicated that you do know some stuff about baseball, but you were willing to you weren't trying to put on front, Hey. So I kind of remember that story when I deal with people that have backgrounds, and believe me, there's no way to be culturally competent all the time with everybody. It's just not possible.
Right, that's true.
So
it's not possible.
Can I jump in there?
Oh, yes.
So I loved literally every word of that, because I haven't heard that from your perspective, from a clinician's perspective, but from a patient perspective. I know you don't like that word patient, I'm sorry, but from our side of things, my general rule is if you're looking for a therapist, lots of people I know, when they're just getting into therapy, they meet the first therapist and it doesn't go well, and they're like, oh, I guess therapy isn't for me. And I'm like, no, that's not, you gotta keep going, because you gotta find the right match. And for me, the definition of the right match is find someone that you're excited to go see every week. Because I've had therapists where it felt like a chore just to get on that subway, to go over there. I'm like, I don't want to do this. Why am I doing this? If that's in your mind, that's not the therapist for you. But my current therapist, I'm like, oh, I have therapy today. What are we going to work through? We got to, if you think of it as a collaboration, if you're working with someone who's creative and who will spark your mind as you spark theirs, then you're going to be excited to go there. And that sounds to me like what you're describing. And so that makes me think that you're probably very good at your job. But I met some clinicians who are, less so. Which, I mean, maybe I shouldn't say that. Maybe it's just a bad, mix. Maybe it's a bad match. Maybe they're not, maybe they should have a different patient. But yeah, I think my bright line rule is like find someone that you're excited to see. Not like you're excited to see a friend necessarily, but like someone like you're excited to talk to and, collaborate with, like a partner in this, endeavor. Yes, that's what I would say from our point of view.
Well, can I add one thing to that? Also, know yourself and ask the right questions. Don't just go in there blinded and say, okay, I'll take that medication. Okay, if that's what you say I have. Google is my best friend, even though Ken tells me to stay off Google. I go on Google and research everything neurotically. And I have to understand it. And because if you don't know what's going on with you, then how can anybody help fix you? I mean, that's what happened to me 17 years ago.
Right. Well, and that's what Sarosh is saying about the collaboration. And Vinay, you're right. I mean, we know that there are different theoretical orientations that definitely operate a little differently in the therapist, patient, client like relationship. In CBT, we operate differently. Right? Collaboration is critical because literally the impairment and the challenges every day, right, really weigh on individuals. And so they're coming in looking for help. We want to understand exactly what we can be of help with and how best we can do that and offer some hope and some relief, right, in that vein. So, I mean, it could be a mix of both, clinician, patient, all around.
Yeah.
Vinay, was there anything else you wanted to say?
Yes.
Yeah, I have to. Yeah,
like 6 to 10 things. Give me a minute.
go in. Yeah, do it.
So I think this is like an amazing discussion. I'm loving this, but I feel like I want to make something clear, which is like we're talking a lot about problems and obstacles and difficulties and like how hard all of this is. And I think Sarosh actually described it as, David versus Goliath in the sense. And that's certainly true, but I also want to leave everyone listening to this with like a little, smidgen of hope, which is, this is me as an organizer talking, this is what I do, right? So I would first like to point out, we mentioned Medicare-for-All before, and the idea that if you're sick, you should see a doctor. Like 4 years ago, that was, laughable. Like everyone was like, what are you talking about? Like that's never going to happen. And it might not happen immediately, but in 4 years, so many more people are on board with that. So many more people think it's a viable idea. Like we've made tremendous progress in 4 years. So who knows where we'll be 4 years from now? That's one thing. And let's also not forget the moment we're in right now. Let's not overlook the fact that we are amidst one of the most revolutionary eras in American history. And so much is changing right now. So much is on the table about how we should be structuring our society. And we have school boards and cities and states across the country talking about divesting from the criminal justice system. And, the logical next step is, okay, where are you putting those resources? Are you putting them into health? Are you putting them into mental health? So I think right now is the best opportunity to be doing this work. Maybe in my lifetime is the best opportunity to be making the argument that our community should be getting this funding. There's a different way of approaching these problems. And people are listening to that argument right now. Right now is not the time to ask for too little. Now is the time to ask for as much as we can possibly get. Now is the time to every change you want. Now is the time to do it because people are seriously asking these questions. And as you can imagine, in my line of work, I very frequently hear people say, why was I born into this era? This administration, this leadership, why am I alive now? This is so awful. This is terrible. And I tell them, I don't see it that way because we're not cursed to be in this moment. With these enemies and obstacles, we're blessed to be alive at a time when we can actually transform this country. How many people get a shot at that? Most people don't. So I'm grateful to be alive doing this work right now. I'm grateful to be on a town hall like this and having people, engage in these ideas because I think right now is fertile ground to create the world we want. And so I'm excited that we can all do that together.
Agreed. Well put. Yeah.
Absolutely. Yes. Not only on that global level, being excited about an opportunity, but I know it's really critical for the community. And I say, as patients, clients, and therapists, right, loved ones, family members, to see Tawana and Vinay both here sharing their stories and not just overcoming like severe impairment at times, but you both are advocates and activists, right? And so anxiety couldn't even stop that, right? Like brought you into this moment, even with a story in such a loud voice to bring into this space. So, I mean, Sarosh, I don't know about you, but I feel excited as well. One thing that drove me back into school is that there are only, out of all of the therapists, psychologists in the US, only 5% are Black. 5%. And yet, we make up a huge part of people that are seeking treatment and also people that are left out of treatment.
Yep.
And so I'm excited about the opportunity as well to be involved and connected and passionate about this, you know, whether it was the moment or not, but it's really nice to have the environment support that. I was looking in the comments. I saw a question about training in India. Does anyone know about mental health treatment or training in India, and or want to speak to maybe some of the stigma or some of the common shared cultural issues that might be present? See somebody.
Vinay, you got any ideas on this one?
I'm going to defer to you on this one.
India's okay. So I'm trying to be diplomatic.
Sure.
They're bad. I mean, their mental health system is bad. So I won't be diplomatic. It's really bad. So I don't know what to say. I mean, if you think fee for service in the U.S. is bad, it's way worse.
Yeah.
So I'm not even sure. I actually looked into this in a very cursory way. I'm not even sure what the legal. I don't like here in the U.S. There are state boards that regulate psychologists, state boards that regulate master's level therapists.
Right.
I don't think there are any state boards or countrywide boards in India. I could be wrong.
Right.
For therapy, it's really bad. So I don't know what to tell you. And you know, Jessica, or actually, sorry, it was Vinay. Vinay, I appreciate your optimism. I am inherently a pessimist who is desperately trying to be optimistic.
Yes.
I need that kind of. I need someone to say stuff like that. So that's good. Because I don't want to be a pessimist, but it's my nature. So, but I'm trying to change. I'm trying to change. So, but anyway, you know, I think the lack of structure in other countries in terms of regulating therapy could be an opportunity. And I know there are organizations that are here in the U.S. that are trying to use that to you know, build out some options for people who struggle with OCD in those places. But you know, I tell my clients, like, they're going to look back on you know, this the 21st century, you know, and say, boy, they were in the stone age of mental health treatment.
Right.
I mean, we're sending rockets into space, and that seems like it would be very complicated, and yet we can do it.
We're doing it.
And yet, what kind of mental health system do we have? It's not great. And so, you know, we have to do the best we can with what we've got. I don't want to be too negative. There are a lot of positive in what's going on and what we're trying to do, but we're still in the Stone Age, man. This is Jurassic CBT that we're doing. So, you know, it's going to get better. But I think we have to keep thinking about, you know, what steps do we take to get things better and better. I mean, there was a time when we didn't even have to be accountable as therapists. Now at least we have evidence-based therapies that say, you know, this is a treatment standard to treat OCD. Are you adhering to that? That was a huge improvement from where we were. When you think about where ERP started, I mean, honestly, real ERP really started in the 80s. That's not that long ago.
Right.
I mean, yes, there were some movement in ERP treatment in the 50s and 60s, but it didn't really start until the 80s with Edna Foa and her work. That wasn't that long ago. So we're still in the early phases of it.
Also, just to mention, I saw it was posted down in the comments. IOCDF does offer trainings, and so I want to encourage any clinician that's working with a population that's very specific. If IOCDF has a training on it, has information and material, they are open to sharing. If they don't, they want to know, right? This is why we're here, because we want to know how we can make this more inclusive and accessible. So definitely keep that in mind. I had another point that when we were preparing for this town hall that some of us were talking about support and group support and communities that are specific to minorities within the OCD community or communities where minorities are welcome. So Vinay shared about coming to the conference and being in the room of 2,000 people and having a shared experience there, and how we can just always, take it up another notch and have faces that look familiar. So if Vinay and Tawana, I also know Tawana has a specific thing too. So I wanted both of you to share a little bit more about those spaces. What would you like to see, if you ideally, and then what are some of the challenges that remain and then maybe some of the challenges that you've overcome to join those spaces?
Oh, I could start. I'm not going to say the organization that I have an issue with. But anyway, here in Cleveland, I don't know if anybody ever been to Ohio, Cleveland specific. We're segregated. Caucasians stay on the west, and mostly urban people stay on the east. Minorities stay on the east side. So when I was talking to Ken, and I was like, you know what, I want to do this group therapy thing. I want to do therapy with people like me. So he was like, contact this specific group. I contacted this group, and they told me, yeah, we do have support groups, but they're all the way on the west side. How is that helping me? So then I was like, okay, do you guys have groups over where, I am, where the people are? And they told me, well, no, we don't think there's a need, is what they said. And so when I started my nonprofit, I got in touch with them again and was like, hey, let's work together. Let's do this. They stopped calling me back. They stopped answering my emails. So I went to MHA, the Mental Health of America, and I got my peer support certification. So I'm going to start doing, once COVID is over, support groups for non-minority people with OCD. But I won't say, I want to say the name of this organization.
So that's a case of someone, right? You can't find it, right? Be an example, right? And two, it spoke to number one, the lack of access, which it just remains throughout healthcare and all the things that make our treatment better and really support in the communities.
Mm-hmm.
But I'm disappointed to hear that even as persistent that you were, right? Because sometimes that's all we can ask is to follow up and to be, really persistent in trying to have your needs met. And that does fall short sometimes. So thank you for not giving up. And you're going to help.
I want to say something else, because you shouldn't even open this can of worms, because I can't get on my soapbox. This group is a huge group. And it's funny to me because they are the group that everybody in the mental health community are told to go to for these services and stuff. And it's just amazing to me that you see a group of people and you guys are not even trying to do anything to help them.
Right.
And it takes a person, an accountant like me, to go and get what they have an army to do to get it done. I'm done. I'm done saying what I have to say.
To one of the comments, you are speaking for the voiceless, my friend. So keep it up.
Tawana, why do you think this happened? Why did they react in this way? What's your take on this?
I was told a couple of different things before I wanted to actually collab with them. And one was no one reached out to them in the urban community for a support group. The other one was they don't feel that it's a need. So their services go to where they feel it's a need.
There's different kinds of ignorance. And the worst kind of ignorance, the kind of ignorance where you don't know that you're ignorant.
Mm-hmm.
The worst.
Absolutely. I mean, just to be specific, research actually shows that minority communities, we benefit better from help being specifically offered, right?
Right.
Going out and seeking, there's all the barriers, access, the distrust, the where do
But
I
this
start?
organization, because Jessica, you know the organization,
Yes,
they
ma'am.
also
Yes, ma'am.
offer education. So it was just mind blowing to me. And it still is. And I get ticked off every time thinking about it in that group.
I understand. And I'm so grateful that that need that you understood specifically and went ahead to address it. And I hope others in the area are able to not only benefit, but follow in your footsteps as well. Vinay, want to share?
Sure. Very different answer. That was a great answer. I had trouble following that. I think the question was about like what spaces do we feel comfortable in terms of dealing with these issues. Is that the question?
Yeah, around there. Yeah.
So I guess I'm when I'm not organizing, I'm a writer, so I'm always drawn to like creative spaces, and I feel like when people are trying to express what they're dealing with and like express themselves, like I talked earlier about this being like the shame illness, right? When people are trying to combat that and really kind of express themselves, some people like can do it on this town hall, some people can write it, some people can sing it, some people can like paint it. I feel like making spaces for all those things are great. And I hosted an open mic at the OCD conference, I think 2 years ago. And, of course, it's the first time I've ever done anything like that. And of course, I have OCD, so I was like super anxious about it. But I felt like no one was going to show up. And like 200 people came, and we went for like 2 hours and 20 minutes. And like so many people came up to me afterwards saying like, oh, I like literally never told my story before. I'd never like expressed it. And then like you created this space where I felt comfortable doing that. And like, again, like credit the IOCDF for creating that space. Like I didn't create it, the IOCDF did. And that was amazing. I'm not sure if we're doing it again this year because I'm a little confused about the whole digital thing. But yeah, that sort of thing is great, I think, like open mic spaces and creative spaces. It's like I literally mean like a physical space, like that you can
Absolutely
that you can inhabit and like enter and feel free of shame. Like everything I described earlier, like creating a space where you feel free of shame is like so liberating, especially for people with mental illness. Especially for people with OCD, like generally people don't understand even what that means. For someone like me, even like, again, within that subset, having like these violent thoughts and people who have, pedophilic thoughts, violent thoughts, people who have relationship OCD, there's all kinds of specific things that people, are scared to talk about. If you can like take away that shame and like create a space where people can be creative and like actually make something, I found that to be like the most moving thing.
Yeah.
That's also great feedback, right? For larger organizations to have that 200 people will show up to take an open mic, right? And an opportunity to be heard and to have it in a form that allows them to feel a little more free, right? And connected. So that's a huge thing. That kind of just reminds me again, within cultures, there are certain ways of expression that are more commonly used and rehearsed and accepted. So yeah, I think we've all seen this before. Somebody write a poem to talk about a tragic event, and then all of a sudden, when that's shared, the community is able to respond and understand and interpret some of that's happened. So I hope it happens again. I'm excited about attending a possible open mic, and appreciate you, Vinay, for stepping up into that space and offering that to a whole group of people, even as IOCDF offered that space to you. Some of the other thoughts, I think we got to kind of our biggest themes, but I know all of us have, certain interests that brought us all here. We have 20 minutes? Am I reading this correctly? And I'm going to look back through the questions, but if there are any other thoughts, go ahead.
I just noticed Stacy mentioned something that Stacy says, I can't feel free while this pandemic is going on. I don't think we've touched on that yet.
And I know Tawana's been talking about some things that have been thwarted because of COVID.
Yeah, right.
So let's talk about like all the things, right? That have shifted.
I mean, I can say personally, I'm usually a super social creature, very extroverted. I've been alone in these walls for 4 months. And, if I'm struggling with that, I'm sure lots of people are. And you're managing depression, you're not supposed to isolate. I mentioned before I was in the hospital for 8 days. I came out of the hospital and went straight into COVID isolation, which is usually not what they recommend when you're in the hospital for being suicidal. They usually don't say, just isolate for 4 months by yourself. So that's like what I was dealing with, and lots of people are dealing with that to various degrees. Managing depression, anxiety, OCD without your social network, without your friends, without your family. That's so difficult to do. So I think that crisis combined with the kind of, policing, the militarization of police, the criminal justice issues that we're dealing with right now, I think those twin crises are really impacting people's mental health, which is part of why I said at the start that I think having this conversation now is more important than ever. And again, COVID, of course, is affecting brown and black communities disproportionately. Again, if we talk about the policing, I've been on the front lines of these protests, like you see the just complete abject brutality and violence over and over again. And these images are being streamed across the country to everyone. So like, how is that affecting people? All that traumatic imagery. So I think right now, like having discussions is incredibly important. So thank you, Stacey, for raising that. I think investing in mental health, investing in mental health resources is so important right now because people are they need assistance.
Tawana or Sarosh, you want to share a little COVID reflection insight?
Well, right now, my main thing is self-care. And with my organization, on my website, July is Self-Care Awareness Month. And I think that you have to take time to actually wind down. And I'm not promoting anything, but I meditate on a regular. I cut my phone off, put it on Do Not Disturb, and I don't deal with the outside world for at least an hour a day. And that refreshes me to a point where I'm able to keep going through. I personally like the isolation. I like being in my house. I'm not going to lie. But I'd rather be in my house than outside. But I mean, I know other people. So the only thing I could say is self-care. You can read a book, journal, watch TV. NCIS is a really good show. And not promote really good show. I mean, there's other things you could do for self-care. I mean, just take care of you. And that's the only thing I could say about the pandemic. And stop watching the news, because that's the best thing.
Sure. I'm actually curious, Jessica, what's on your mind? Because you've been moderating, doing a great job. I'm actually curious.
You all are on my mind. I'm actually really enjoying this, and even the comments. I'm really enjoying seeing people kind of literally resonate with what's being said, because I know how excited I was in speaking with all of you about today. What I'm thinking about with COVID in particular, that's interesting you asked me just now, because that's definitely, I want to just reflect to everyone that a well-adjusted person had no idea what to do during the pandemic. And all right, there are not a lot of us that are ideally well-adjusted, right? So this was unprecedented. It's literally what we ask our patients to do, our clients to do all the time, tolerate uncertainty. Mm-hmm. And then for how long? I never have asked anybody to tolerate indefinite uncertainty. So even asking us all to do that in this space has been very, very hard. And when this first started with isolation, obviously I thought of people who do really well with their consistent treatment routine that might include that one trip from the house that week and have some benefit and relief. But also, I knew, because in our country, minority communities continue to bear the brunt of anything that is systemic and widespread. And so my issue is, are we going to have enough resources for everyone who was just barely hanging on with their clinical presentation before COVID? And then on top of what will be, I think, both an acute and long-term trauma effects that we're going to see from this. So it just makes me almost more urgent to have training and make sure we have clinicians and counselors and support groups and people to wrap around the communities that are going to need it. I also know that people will come into treatment that had been avoiding it. And so I'm excited about that as well, that we'll have an opportunity to do that. Just thoughts on everything. A lot has been said because I know we shared a lot of similar themes and thoughts as we were preparing for the town hall. But thank you, Sarosh. I appreciate that.
One interesting thing about this whole, in a lot of ways, terrible experience is that for us as therapists, those of us, hint, me, who are skeptical about video therapy, especially exposure and response prevention, there's published data that shows it works via video. And in my practice, and when I talk to colleagues, they're saying the same thing. Like they're saying there's unique challenges, of course. But hopefully one thing that is coming out of this is, we can actually do video therapy, and it's going to help. And that would kind of help a bit of the issue that Tawana touched on, which is, where are you geographically located? Because, now all of a sudden, if I live in a neighborhood where there just don't happen to be a lot of therapists. By the way, I don't know if this is true. I'd heard, and I can't find the source for it, but one of the big criteria for successful therapy is how far away you are from the therapist. So if your commute therapy is short, that's actually a really good indicator of whether you're going to stay in therapy. So if you have to, I had a client, this was years ago. Her mom would drive her an hour and a half to see me. An hour and a half coming, an hour and a half going. That's crazy. And then I had another client, he would have to take 4 buses to come see me. And I would feel so bad because now I think about those days and I think, like, we could just do video. I mean,
Yes.
He would tell me, like, I couldn't do my homework because I got home at like 9 o'clock because I missed the 6 o'clock bus. So I had to just wait.
Wow.
One of the issues with privilege in any of its forms, economic privilege, etc., is that when you're privileged, a lot of times you don't know that you're privileged.
Right.
And so when I worked with him, I was thinking, I am so dumb and so lucky. I didn't even know how lucky I was that, I don't have to worry about 4 buses. I don't have to worry, like, Sarosh, we got to wrap this session up because I got to get out of here now because, boom, I don't want to miss my 3rd bus. So these are kinds of things that COVID and video therapy now are going to have substantially different effects. And I'm so hopeful that insurance companies, again, I'm trying to be diplomatic, wake up and don't take away the openness they've had during this period and continue to reimburse in commensurate ways so that we can do what we do. But we'll see. I'm already starting to hear about how things are changing and how companies are starting to, they're planning to change how they reimburse and for video sessions in the wrong direction. So it's going to be a fight. It's going to be a fight.
I have to say, here in Cleveland, during the whole COVID thing, and because they may shut us down next week, we don't know. But the Cleveland Clinic said that all video sessions are on them if your insurance doesn't pick it up. And I think that was a really, really big thing for them to say.
Who said that to me?
The Cleveland Clinic said that all video sessions are on them until after the COVID thing is over.
Wow.
If your insurance doesn't pay for it. So I think that was a really good and beneficial thing that they did.
Me too. Yeah, that's good.
Vinay.
Yeah, so I noticed we only have 5 minutes left. We don't have to discuss this subject yet, but I would. Is it 5 minutes? I think it's 5 minutes, right? About 5 minutes. I do want to raise something we haven't talked about yet, just to flag it for people, which is especially important in minority communities, the idea of masculinity and like men specifically dealing with these issues because they're taught, to be so stoic and to not show any sort of vulnerability. And Sarosh actually mentioned that in terms of working with athletes. And I think that's particularly interesting and something we should flag that we really need to work on in minority communities. And the first time I actually wrote about my mental illness, it was about my inpatient treatment. And I'm a big basketball fan. And so I wanted to package it in a way that would actually get people who are in these like hyper masculine environments to like read this story, not just people who care about mental health. So I talked about how every day from like 9 to 5, I would do the treatment. And then every night I would watch NBA basketball. This was the year that LeBron won the title in Cleveland, which is important to me.
Big deal.
So I framed it that way, and I didn't put it in a mental health outlet. I put it in a basketball magazine, in Slam magazine. Props to Slam for being open to that sort of article.
Right.
I'm surprised they were. And so I got people who were like, tuned into this hyper masculine sports environment to be reading about mental health and vulnerability. So I think that's important as we move forward. Like, how do we reach that community? Not just people who are opting into these town halls. Anyone who's on this town hall right now is probably like somewhat comfortable being vulnerable, right? But like, how do we get those people who aren't and who like wouldn't even think to seek treatment? I think that's something we should brainstorm. Yeah.
And so just along in that, you're getting in on that question about like increasing the awareness in these diverse communities. I know for myself, I obviously am a part of organizations for Black therapists, Black psychologists, but also coming to some understanding about the unique presentations of anxiety in certain communities that might be present. Right. And so Tawana mentioned scrupulosity, right? And we're going to have another town hall that's talking about spirituality and religion, but you want to access some of those religious leaders, or just when you're talking to that community, maybe it's not generalized anxiety that you're going to speak on. You might want to say, how many of you have ended up engaging in a compulsive behavior around prayer? Or worship or things like that. So I kind of advocate for clinicians to be bold in their clinical knowledge, right? Because we work very hard and study it. And then when we're in these communities, say, I can speak to that in that way that it presents as a clinical impairment, right? And so religion is one of them. In the Black community, hair, right? Racial identity, right? These sorts of things come with a lot of anxiety. And we can understand that clinical presentation outside of all the socialization that just feeds into kind of stereotypes and you should be okay. So that's a piece of it. But I would say it takes more people. I think we talked in preparation for this that I think Vinay was saying there could be 40 of us and we still wouldn't hit everybody and all these unique people that we can serve with our anxiety expertise and the support that we can offer the community.
Well put.
So we do have like about 5 minutes. And then we can go over a bit if people are willing. I'm taking note of this.
Yeah, they're saying we can go over, so I'm just going to keep talking.
Yes.
There's in terms of reading, one of the best mental health essays that I've read, which inspired lots of my writing, was by Michael Denzel Smith. And he wrote Invisible Man Got the Whole World Watching. don't know if you understand that reference, but you can look it up. And his book of essays is really, really good. And there's one of the essays is on mental health, and he talks about growing up with panic attacks and having no idea what they were because he had no one in his community modeling like what that even meant. And so like I think it was around, he was in school during the Iraq War, and he heard like loud noises, off in the distance, and he thought like we were being bombed. And he just like burst into tears and had this huge panic attack, and he rushed into his parents' room, and he didn't know like how to articulate what he was feeling. Like he just physically did not have the words for like this sensation inside him. And like he talked about, he just had no one in his community modeling it. And he said like he knew people who were locked up, but he didn't know anyone who had anxiety or depression. And then I think he stumbled upon, eventually he stumbled upon Bell Hooks, who wrote once, I think I have the quote here, "I found myself saying again and again that mental health is the revolutionary anti-racist frontier African Americans must collectively explore." And Bell Hooks, as they did for so many of us, completely changed his life. And if you have not read Bell Hooks, I strongly encourage you to do that. If you remember nothing from what I said today, please read Bell Hooks. But yeah, so that like completely changed his life. And yeah, he just had no models in his community, talking about those things. So he couldn't even articulate to his parents what was wrong. So it's a great essay. I would encourage everyone to read it. There's also basketball references in there, which I love. So yeah, I just wanted to put a plug out for Michael Denzel Smith.
And Bell Hooks, thank you so much for that. Yes. Critical reading. Critical reading for anyone working with the Black African-American population, and critical reading during this time, right now. Very, very relevant. Very relevant. Let me actually check the chat. Greg is saying any rapid thoughts. I like that. So any rapid kind of thoughts here?
I will put in a plug that I think we have a stigma panel next week, right, at the same time?
Yep, there's a link for the upcoming programming listed. This is going to be an excellent, unique month, and we're playing the long game here at IOCDF. We're looking to continue this kind of content well into the year, get more creative, be more responsive, right, to the needs of the community, not just the OCD community, but the community as a whole, and looking to highlight the minority participation and figure out ways to get better.
Can I just add one thing too?
3 things.
I gotta add 3 things?
Yes.
So everybody watching, bear this in mind. You have an opportunity in this organization. This organization actually wants to hear you. They actually want your input. They want you involved. The IOCDF is the only mental health organization I know that integrates research, scientists, therapists, individuals who struggle with OCD and their families together. We are going to get better with this stuff together. We're not going to be able to do it apart. We have to be together. So you guys have to be involved, and you have a route to be involved. Get involved with this organization, speak your mind, and do some work. It's not going to be easy. We're trying to do the same thing. We really are. And, there are opportunities for you to be heard right now. And, they want to listen. It's really an awesome opportunity to be involved and speak your mind. And some of your ideas are going to be awesome, and hopefully they'll be taken up. And some of them may not be. And, we'll figure that out. But speak up and play a part. Advocacy is so important. It addresses issues of shame and stigma, because what you start to realize, I'll tell you this quick story. My first IOCDF conference, I got onto an elevator, and a bunch of kids got on the elevator, and it was clear that they all were on some kind of conference scavenger hunt. They all had OCD, and there's some scavenger hunt. And I started crying, which I do very easily, I admit. But I started crying because there were all these kids, and again, it was just an elevator ride, but I could tell they all felt like they had found some fellowship, and they were doing this little scavenger hunt together. And there was this rare opportunity on this weekend to relate to another kid their age who was going through something similar, and they weren't in an environment where they felt like something was wrong with them. They felt accepted, and they felt a part of something bigger than them. And we all deserve to have that feeling. So you got that opportunity, get to it. Get to it.
I want to address, I've seen a comment talking about in the African-American communities that it has to come from pastors or whatnot, the religious community. I agree on that. However, there is closed-mindedness there when it comes to religion. They do not want to hear it. And believe me, my father's a pastor, Baptist faith. I cannot even talk to anybody in his congregation about it because they're closed-minded on it. So I think that for us to even say that, let's go and educate them, we have to do that with baby steps because they are really, really closed off on anything outside of spirituality. Because psychiatry to them is of the devil. And I'm just saying they don't believe in that. They believe that the Bible, and I'm not knocking nothing about religion or anything like that, but I'm just saying that they believe they have one mindset for how they believe in stuff. So that has to be done with care and baby steps.
That's such a tough one, isn't it? Because I hear you. I agree with you. And I don't really know what those baby steps are. Do you have any suggestions?
So uniquely, I was trained in Los Angeles, though I'm physically located in New York City now. There are two what are considered mega Black churches in Los Angeles that have full psychology programs. They actually have psychology internship programs. So there are opportunities in any faith or belief system to find leaders that are interested in embracing and collaborating with treatment providers. And I'm being not just therapists, right? We know that other, like just a medical doctor, a pediatrician, there could be certain religions that really struggle with taking medical advice and understanding the science. So those churches, you would look for those faith leaders that demonstrate an understanding and a willingness to collaborate. And when it comes to working with patients and clients, you can talk to them. So for Tawana, somebody might say, well, her dad's a pastor. Obviously, religion is very important. And she's like, yes, and, right, I'm interested in the treatment, right, that's there. And so to have a clinician be able to respond to both sides of that. Somebody that grew up in a faith system may not practice it very closely, right? And some of the things that they may have held closely are no longer a barrier to treatment. But if it is, and I know in Los Angeles with the Orthodox Jewish community, right, which there's some very specific presentations of OCD, you can find leaders that have been receptive. So like if there's something specific, I just know those places in Los Angeles because I had an opportunity to work with them, and they're huge churches that encourage psychology, right? They have psychologists and they are fully with that. And also there are plenty of psychologists. There are tons of clinical and doctoral psychology programs at seminaries, right? We know this as well. And so those programs are accredited, and they do have therapists who have both a religious theology background as well as psychology.
That's great. That's really great. We have to build a list here.
Yeah,
absolutely.
Because the Baptist church I know do not.
So with them, we would offer, like Sarosh or some other therapists who have a big personality, right? We would want to go and meet with them because we know that there might be a different kind of resistance to accepting it. So we would, as clinicians, we'd want to send in people who are able to respond to those questions and that resistance, and not somebody who doesn't know how to make headway with that group.
Yeah, I'm reading this scripture, Philippians 4, 6, and 8. That's what my father used to say to me all the time. All the time. Bring your worries to God, and the grace of God that transcends all understanding.
Wow. So it sticks with you. It does.
Funny.
So any final thoughts? I've had a blast.
Should we do one final thought from each of us?
Oh, yes. Yes.
Who wants to
start?
I guess mine would be what I said earlier, that I think these obstacles are incredibly real and difficult and hard to manage, but I think this is the best time to be doing that work, and I'm really excited to be doing it. I think, if I can find it quickly, so next week is stigma, the following weekend is racism, and the last weekend of the month is trauma. So, I mean, if you're looking for ways to get involved, like, those are 3 ways right there. And beyond that, if anyone wants to reach out to me, I'm happy to plug people into advocacy. And it sounds like everyone on this panelist has ways, we can all plug in. I think this is a great time to be doing this work, and I remain optimistic. That'll be my final word.
Awesome.
My final thought is, one person can make a lot of noise, but a bunch of people their voices can break windows. And I mean, us as advocates, one advocate, and I'm in Cleveland, and you guys are in New York and LA. The thing is, I can make my noise here, and you guys can make your noise where you are. But if we come together, we could shatter windows. And I think that this is like a first step of us being on the same page and trying to break some windows.
Thank you.
My final word is, do your part. It really is, every day I get emails from some business telling me how they appreciate or how they feel for us during shelter in place during COVID, or how they support a movement, Black Lives Matter, let's say.
Yeah.
And I think that's great. A verbal assertion is great, but I think it's really important to do some work and do it for a while.
Yeah.
And the way I was raised is, you do the work, you try not to talk too much about it.
Yep.
Because then it's about the work itself.
Mm-hmm.
So, and that's for all of us. So I agree. I echo Vinay and Tawana, and I'm probably going to agree with what Jessica's about to say. That's my final word. And thank you, IOCDF, for putting this on and giving us a chance to share some of this stuff.
Okay.
Yeah, I'm really echoing you, Sarosh. Collaboration from therapist to patient client. Let's take it to that next level, right? Organizational level. As Vinay and Tawana have shared, the advocacy efforts, it is the time to get involved. It's the time to be heard, to make an incredible impact.
Right.
So it's time for action. That's how I feel.
Mm-hmm.
Like, it's just time for action in any way that you can do it. And this is a great start. Also, really want to give IOCDF just a lot of kudos on having a diversity advisory council that was active long before the current climate sparked. And so we were in place and ready to be responsive to some of these things in a really unique way. So that is incredible. And I hope to see more of us at these town halls. I hope they continue to do the town halls in this way. And I hope everyone enjoyed this, found it of benefit, and comes back. All right.
Thank you, everybody.
Thanks.
Thanks.
Thank you.